Good evening, everybody. This is David Weisberg from the Federation for Jewish Philanthropy of Upper Fairfield County. I'm pleased to welcome you to tonight's webinar, which we're calling Insights from an Expert with Dr. Harvey Risch. At this really challenging time, our Federation is continuing to look for ways that we can bring our community together, if not physically, then virtually. Sometimes that's for very joyful programming, as we did with our community-wide post-Havdalah song circle on Saturday night. And sometimes that's to learn about more serious topics like the situation that we're all facing now and the topic that we're gonna look at tonight with Dr. Risch. I was lucky to meet Harvey just last week. We had our Federation co-chairs, Deborah Hockhauser and Mindy Siegel, convened a conference call of congregational presidents from around the community to talk about how we could work together. And while Harvey is not the president of Congregation Achavat Achim, they designated him to participate in that call. And it was only then that I learned that we had an epidemiologist and a professor of public health from Yale as part of our Upper Fairfield County Jewish community. And I'm so grateful that Harvey agreed to participate in a webinar and do it on such relatively short notice. Before I introduce him and read you his bio, I hope that Harvey and I are gonna have a conversation for 20 minutes or so. And then what I really wanna do is leave a lot of the time for those of you who are attendees, participants in this webinar to ask your questions. And I want to tell you that we're going to do that in three different ways. One, I have a couple questions that were emailed to me ahead of time. Two, you have an opportunity to write a question on the chat feature. Three is my most preferred way, which is if you can raise your hand using the raise hands function, I will call on you and switch you from an attendee to a panelist and bring you live into the conversation so that you can ask your question in real time. I tell you that now for a couple of reasons. Number one, when I bring you in as a panelist, if your video is on, there's a potential that you'll be on video, and I want you to know that. Because I wouldn't want anyone to be surprised that all of a sudden they're in their pajamas on a webinar for the entire community. And secondly, I want to ask, if I bring you in to ask a question, that you ask one simple limited question so that we give as much time as we can for as many people to ask questions. Because I know that there's certainly a lot of information that everyone is seeking. So let me introduce Dr. Harvey Risch to you. Dr. Harvey Risch is a professor of epidemiology in the Department of Epidemiology and Public Health at the Yale School of Public Health and Yale School of Medicine. Dr. Risch received his MD degree from the University of California, San Diego, and PhD from the University of Chicago. After serving as a postdoctoral fellow in epidemiology at the University of Washington, Dr. Risch was a faculty member in epidemiology and biostatistics at the University of Toronto before coming to Yale. Dr. Risch's research interests are in the areas of cancer etiology, prevention and early diagnosis, and in epidemiologic methods. He is especially interested in the effects of reproductive factors, diet, genetic predisposition, histopathologic factors, occupational, environmental, medication exposures, infection, and immune functioning in cancer etiology. His major research projects have included studies of ovarian cancer, pancreatic cancer, lung cancer, bladder cancer, esophageal cancer, and stomach cancer, and of cancers related to the usage of oral contraceptives and non-contraceptive estrogens. Dr. Risch is associate editor of the Journal of the National Cancer Institute, editor of the International Journal of Cancer, and member of the board of editors, the American Journal of Epidemiology. Dr. Risch is an author of more than 300 original research publications in the medical literature, has an H index of 86, and is a member of the Connecticut Academy of Sciences and Engineering. I hope reading your bio didn't take up half of the time that I made available to myself. Harvey, Dr. Risch, thank you so much for making yourself available to us tonight.
Thank you. My pleasure.
And so I want to ask you, first of all, your background in a specific, area of research and interest and focus. Tell me how your work has shifted, if at all, the past couple months.
So, my limited expertise in infectious epidemics actually stems from my PhD work, in that my doctoral dissertation was on mathematical and statistical modeling of the infectious epidemic processes. And I did a little work in the postdoc before I switched to working on cancer to modeling what was then called the toxic shock syndrome, which most people don't remember. It was a brief epidemic linked to bacterial contamination of tampons that came and went very quickly compared to what we're facing today. Since I spend maybe 3 or 4 days a week in general working from home because I can work by remote desktop to my office computer, I do that a lot. And so for me, logistically speaking, it wasn't much of a change to work 7 days or 5 days a week from home, more or less trying to maintain the same degree of concentration and focus on things while being inundated with all the details of what's happening around us and the coronavirus, and talking with all of my colleagues, my infectious disease colleagues, about what they're dealing with and trying to understand and make some common sense out of all of this.
And so have you been brought into those conversations? Has your work changed at all?
Yes, and I think that all of us in the School of Public Health have been brought into it, both as scientists and experts and as activists or volunteers in helping out the public health process in New Haven or when called upon by external media agencies and so on.
Right. So tell me, when it comes to understanding a situation like this, do you go back to historical models and patterns? Is that the starting point for predicting and understanding what's going to happen going forward?
Yes, in fact, it is that to a large degree, the fundamental behavior of epidemics still work according to the mathematical models that were prevalent in the 1970s. And yes, we have lots of refinements now. Now we can map them to populations with differences in population densities because of cities and locations like that. Population density high in one place, low in another, and how infections spread by travel, in airline travel today and train travel and so on, that wasn't so common before. But all of those models still work on the same basic idea that people spread disease to other people who are susceptible, and those people either get better from the disease, or they get worse, or they die, and they themselves become spreaders to further people. And so what happens is the basic dynamics is that the population fills up with everybody who mostly recover and become resistant to getting the disease again, or they die off, or the infection doesn't spread at all because there aren't enough new people to get it, because the agent and the way people interact isn't strong enough to support having more cases as opposed to fewer cases. So one of the considerations about how infections spread is each person has to convey at least an equal number of new people into the infection in order for it to spread. So that means that for each person who has the disease, if fewer than on average one person gets it from them, the infection will die out. If on average more than one person gets the disease from them, the infection will increase. And that's what happens locally, and by more complicated modeling, more nationally and internationally.
And has this situation, from the way you see it, your insights, has it worked to pattern? Is there anything that surprises you? Is there something about the COVID-19 situation that feels different to you?
In fact, it's worked more to pattern than I would have expected for any real life circumstance compared to the theoretical models. The infection increases exponentially in the early to middle stages when basically everybody around is susceptible to getting it and able to spread it. And that's the way it works in different places. The slope of how fast it increases exponentially is different in different populations, but nevertheless, that seems to be the way that it's working. And of course, that also tells you two things. The whole idea of that you have to transmit the infection to more people than have it in order for the infection to increase tells you that you have to make the infection harder to transmit in order to suppress it. And that's the whole idea that we're facing now, is what methods we have to make the average number of people you communicate the infection to less than one for each person who has it. And that's where the idea of social isolation, social distancing comes from, is to make the infection less capable of being spread.
So is it helpful in this case for us to look at the timelines and the trends and the arcs and curves of what have happened in other countries with this virus? Or are there ways in which we are as a country are unique, in which looking at, Italy or looking at South Korea or looking at China is not going to be a predictor of the type of trends that we can expect here?
So unfortunately now everybody in the world knows what epidemiologists are. There's no confusion about our term. And epidemiologists are always paying particular attention to what we call the denominator. Who's at risk to be the things that we're studying? So here we're studying the number of cases that occur in the population. And what we want to know is who's at risk to be those cases, and how many, if you're trying to detect them by a test, by a screening test, how many cases that are out there that you miss by your screening test to have a real idea of who's actually affected in the population. And that's something that has differed dramatically from one country to another. So what we don't know now in the United States what our proportion of actual population screening is compared to case finding screening. In other words, today for sure we're screening people who are either symptomatic or have some connection to somebody who was found to be positive. Now, we believe there's plenty of asymptomatic people in the population, people who are carriers of it, but are not manifesting symptoms enough that they're either bothered by it or are seeking some kind of medical attention. And because of that, we don't know how many of those people there are. There are indirect ways of trying to estimate those, but we can't really tell. What we do know is that, for example, Germany has been screening massively on a population basis. So Germany has been screening 150 to 200,000 people per week. That's way more than the number of people who are symptomatic. And so they have found much larger number of cases for their population compared to a country, say, like France, which is following using the same screening methods that we in the United States are using, which is to test symptomatic people and people kind of related either by proximity or living circumstances to positive people. So we don't really know who's out there who's still positive yet. We'll know that once we ramp up this population screening tenfold or more, then we'll start to get a sense of who's actually out there that's positive. Whether that matters or not will be determined by how many cases can be found that would otherwise progress to severe disease. And this will be affected by testing for sure, because we'll find more of those people, but also what's in the pipeline now for trying to treat the disease before it gets to the severe state. And that's also a rapidly developing topic.
Right. So every year around this time, I get a seasonal cold. I have one now, a little bit of a runny nose, a little bit of a cough. It makes me a pariah right now when I go out, because you can't sneeze and you can't cough in public without anyone looking at you strangely.
But why are you going out at all?
It's a good question. In your ideal world, should I go get tested? Should anyone who has any kind of symptoms go get tested? If we had the availability to test, who should we be testing?
So if we had a test for every person in the country and could afford to do that, we should test everybody. But we don't. And the reality is that we have to aim our testing strategies at people who are most likely to test positive without discounting that there are people who are totally unknown, asymptomatic in the population who will test positive. In your case, your symptoms are more reflective of a seasonal allergic condition than even an infectious one. And I should say that one of the things that is, in a sense, good about the coronavirus illness is that its symptoms and signs are very well defined. So if you said, I woke up one day with a fever and I couldn't get out of bed, I was hurting all over, I would say that's enough to go tested, that's enough to be highly likely to be positive. If you said I had a dry cough and a headache, I'd say you have a chance that you're positive, a good chance that you're positive in today's circumstance. A year ago, if you said that, I wouldn't have said that, but today we know that this is what's happening. So I think it's pretty clear cut that the disease, when it can peter along with just a little bit of a cough and a runny nose for a while and not show anything, and then suddenly it escalates and people feel this malaise, these muscle aches, the fever, and so on, and you know that it's happening at that point. It's very well defined at that point.
Right, and so we'll find the people on screening who have the very specific symptoms, and then those who are asymptomatic, we won't catch it all because they won't get screened.
Unless we look for them, and
Right.
we should.
Right.
And especially in places like New York State, which has the highest numbers in the country, where the disease is occurring the most is probably reflective of more people who aren't diagnosed yet or aren't screened positive yet, but are probably there.
Right. So I'm going to ask just a few more questions, and then we're going to open it up to those who are listeners. The last I heard today, there are 40,000, I think, diagnosed cases in the US. I think today was the first day that we had more than 100 deaths in the US from the coronavirus. I think the Surgeon General said in the past day, expect this to be a really bad week. There's also talk of lifting some restrictions a week from now, potentially after a 15-day period passes. What do you anticipate that we should expect when we're told it's going to be a really bad week this week?
I think that means that until we have some reasonably effective treatment for people who are mildly sick to keep them from getting very sick, that the numbers are going to go up and the deaths are going to go up. And I think that Dr. Fauci, when he said that the evidence for the paired anti-malarial antibiotic, hydroxychloroquine and azithromycin was anecdotal, I think he was misspeaking what the evidence was there. I think in his mind, the evidence was weak, and I agree that the evidence was on the weak side, but there was a study published on March 20th, and it was made public, I think, on the 20th or the 21st, looking in Marseille, France, at a non-randomized study, but a controlled study, where there were actually 3 arms in the study of patients who got the anti-malarial, people who got both medications, and controls who got none. And the people who got both did dramatically better after 5 days on the 2 medications. There are some issues with how the study was carried out, so that it's not a bulletproof study, but it's very substantial evidence that there's benefit from these medications. And so I think that while Dr. Fauci was a little reticent to say that we should hop on this bandwagon immediately, I think that you've already seen clamor that people want this and want this available. And I think that's where we're going to go until proven that the side effects, of which there are some, are worse than treating people, even in very mild stages. The French study also, on average, gave the medications to people on day 4 after symptoms started. And I think that we can do better than that we should be able to get, when we're putting people on these medications, on day 1 to 2. And that should matter a lot. If these medications work at that stage of the illness, they should be much more effective even than in the French study.
And in your mind, that timeline can be immediate then, that we ought to be starting with that kind of treatment?
I think that there's evidence that when you have this degree of mortality, that the hazards from these medications, which are not zero, but they're also not that common, outweigh the risks until you have more experience to know more definitively. But these are not new medications. These are medications that have been around for 30 plus years, and we know what the spectrum of side effects is, and we know how people tolerate them and so on.
Right. And what do you see the end of this looking like? Is that we manage it out of existence, that we vaccinate it out of existence, that we develop an immunity out of, how do you see this coming to an end?
The final end will be some fraction of the population becomes immune because of having it, and the greater fraction of the population is vaccinated. Mm-hmm. That will take a year to year and a half. And that's assuming that by the time we have the vaccine out, that the virus hasn't changed and the virus is still susceptible to the vaccine. In the meantime, it's crucial that we treat people who are symptomatic, especially older or immunocompromised individuals who are symptomatic need to be treated, because we need to manage this on an outpatient basis, not on an inpatient and intensive care unit and respirator basis. We just don't have that capacity. It's way too draconian for patients to have to go through that kind of treatment, even when they survive, compared to being managed on an outpatient basis with monitoring. So patients who feel lightheaded or dizzy or something need to have immediate access to their primary care person to be able to see if that's a side effect of the drugs, for example, or they have something else going on. Short of that, I think that if we manage this that way and treat it, what's going to happen is a large fraction of the population is going to become immune to it, and it's going to suppress their transmissibility to other parts of the population. So that causes what we call herd immunity. When a good fraction of the population is immune, it prevents everybody else from getting it because they kind of stand in between everybody and spread people out.
And you think that's about a year, 18 months away?
I think that if those treatments work and they're approved and become widespread, that's 3 months away. Right. The treatments are available. So I mean, and where they're being ramped up to be logistically available. Teva has donated or is donating, I think, 6 million doses of hydroxychloroquine, and I'm not sure where the azithromycin is made, but it's also a very common medication and should be easily available as well. So we should be able to have that on short order, widespread across the US, especially in New York and other places that need it rapidly. And we should be able to get that into the medical system relatively quickly, on the order of a few months.
Mm-hmm. So I'm going to ask you one more question, but before I do that, I want to ask those who are listeners who have questions and want to use the raise hand function, so that I can see if you have a question and invite you into the conversation. I want to ask you, just from a public policy standpoint, are the policies that have been put in place now, staying at home and such, policies that you think are effective, and do you think that they're going to need to be in place for a much longer period of time?
I think they're on the right track. I think they're too late compared to it would have been better if they had been instituted earlier. I think that we're going to suffer economically because of these policies, and especially the longer they're imposed, the worse we'll do economically. I think that that's a trade-off, and that's one of the reasons why we have to medically manage this as soon as possible to allow people more flexibility to start regaining their regular daily activities of life. Now, at the same time, I think that people who are like waitresses out of work in restaurants need to be volunteering or getting employed as delivery drivers for grocery stores and so on. There's a backup in reciprocal kinds of work activities needed to sustain our society under the current circumstances. And so people have to be flexible enough to kind of move around their employment to maintain what they need to maintain until this settles out and they can go back to their regular kinds of employments. It's just that we all need flexibility in dealing with this.
Right. So I have a question that was put in through the chat function from Jeff. It's more of a science question, which is, can you comment on how long the virus seems to live on solid surfaces? Some information says it only lives well in moisture like your saliva. Other information seems to indicate that it can live on a dry doorknob. And so what should we be concerned about the virus living on surfaces in our home or being transferred from one place to another?
I've asked my colleagues this question a number of times, and I don't think there's a clear answer. So to start with, the fact that the studies that say the virus can live on surfaces are ones that are able to detect viruses. That means that the viruses are put into the air in a closed box with the surface material inside, and then over time, over successive days, hours or days, say, then samples are taken off the surface and genetic testing for the presence of the virus is carried out. That's a wholly different issue than whether people will get infected and get the disease by handling those surfaces. And so the question is, how long are surfaces infective if they've been touched, not whether you can detect viruses on them. And I have no idea, honestly, whether the fact that a virus could be detected 2 or 3 days later on an aluminum or stainless steel piece of metal means that somebody doing that and the touching his or her face would come down with the infection. That's just not known.
Right. Okay. So I have an anonymous question, an anonymous question for you. If you're immunodeficient, B cell deficient, are you more or less likely to show symptoms of fever?
Oh, that's a good question, and probably beyond my level of clinical expertise. I think that it's probably likely, but I can't really speak to that.
Okay, so a question about swimming pools. Will swimming pools be contaminated?
Swimming pools may be contaminated, but the problem is the people in them next to each other. I think that probably they won't stay contaminated. I don't think that swimming pools will stay contaminated after a few days, but people are going to socialize and congregate in and around swimming pools, and it's hard to have social isolation in a swimming pool context.
Right. So I have a question from Franny. Once you get some symptoms, does it get worse and worse, or do your symptoms wax and wane for some time and then you get very sick?
Both things happen. So they can wax and wane a little bit for a while until suddenly some internal biological switch is flipped and it escalates in symptom intensity. Other people just wake up one day with a fever and muscle aches and so on and have it. So there is a variable course. I'd say that it's hard to know when is the first date of symptoms when there could be a variable course. The main feature is that it's attributable to this virus is dry cough, shortness of breath, and overwhelming fever and malaise, muscle aches and things like that. So any two of those three is enough to define the start of the illness.
Great. So I'm going to try to bring our first live questioner into the conversation. So David, I'm going to unmute you. David, are you with us?
Yes, I am.
David, so do you have a question for Dr. Risch?
Yes, the countries that have been most successful in curbing the coronavirus have had a policy of sending those who have tested positive to an institution or holding facility for treatment or quarantine rather than to self-quarantine at their homes, where the virus can spread to family members. Why has the U.S. not adopted this policy?
I'm not sure that that's a proven relationship. I think if you look at Israel, you'll see that Israel has among the lowest mortality of any country. Israel's got about 1,400 cases, known cases right now. It's had 1 death. I don't think that Israelis are treating with the medication pair yet. Maybe they've started, but in general, I think that there is a lot of unknowns in how this is managed. And the main problem with having people quarantine at home is you have to get to and from your house, and you need services there. And that means everybody who interacts with you, either going in transportation or living with you, is also likely to get the infection. And so they have to self-quarantine. The hardest thing really is for everybody to stay at home and just not go out for any purpose and get everything delivered insofar as possible. That is a really hard standard to adopt countrywide, but that's really what's required in order to suppress this virus for 2 to 3 weeks at a minimum.
So we're getting a lot of good questions here. I have a question submitted from Deborah. I heard that taking Advil will make symptoms worse and that Tylenol is better. Is that true?
Don't know. I think that Tylenol is always considered to be a safe medication for fever and muscle pains. Advil and the other anti-inflammatory medications, I can't really speak to as far as whether they are actually making the illness itself worse as opposed to treating symptoms.
Okay, so I am going to promote Joel to being a live panelist so he can ask a question. And I'm going to give the disclaimer that Joel is my father. I felt no compulsion specifically that I should call on him, but I'm sure he has a wise question, as he always has nothing but wisdom for me. So Dad, are you there?
All right, can you hear me?
We can.
Okay, Jill has a question.
Hi, I'm Jill's wife, Jill. My question is, last week, a young woman got a trial of the vaccine. Can you give us an update on that? And also, how is the vaccine actually progressing?
I have not heard that anybody has actually received a vaccine from anywhere yet. There are probably 20 different groups across the world actively working on vaccine development. The problem right now with vaccine approvals is it first has to be tested in animals. The animal that's most desired is the lab mouse, a genetically susceptible mouse that can get this illness. It's a very special breed of mice that until about 2 weeks ago was not, or maybe a month ago, was not being made by the companies that mass produce genetically engineered mice. And so they are now gearing up to mass produce these kinds of mice that are susceptible to coronavirus illness so that vaccination can be tested on them. But so all of this is taking time to play out. Once the vaccines are developed, and I'm not sure, I haven't heard yet, but you may know, since I don't follow absolutely everything every day, there may be a report of a new vaccine that has been manufactured, ready to be tested in mice. I'd be very surprised that it's able to be tested in human context yet, because the safety trials have to be done first in mice.
So I want to let everyone know we have more space for questions. If there's more questions, either if you want to raise your hand or submit through the chat function. I do have a question for you. It's a follow-up on the swimming pool question to get more specific. If someone who's infected swims in my condo pool and I go up and swim that evening alone, can the water make me sick?
Probably not. There might be virus in the pool, but that's another question that we don't know the answer to, is how many virus particles does it take in order to get sick? That it might be that the body can fight off 10 or 100 virus particles, but 1,000 would not be enough. So once it's in the water, it's obviously going to be diluted throughout the whole volume of the pool. And so it's hard to know exactly whether it's enough of an exposure to matter.
Okay, so I am going to, hold on one moment. I am going to try to bring Don in, who has a question. Here we go. Let's see, Don should be with us momentarily. There is Don. Don, you're on with us. Do you have a question for Harvey? Don, are you on? Well, I'm going to move to another question and we'll see if Don is able to join us. Question from Rebecca. Are we at risk of lifting social distance distancing precautions too soon and creating multiple rounds of the virus? What's the ideal timing?
The ideal timing is never until we've got this in hand, but we're obviously not going to do that. The paper that did the most recent thorough mathematical modeling of this that came out of Imperial College London from, I think it was from Neil Ferguson, a couple of weeks ago, showed that what'll typically happen, what may happen in China first, is that when the infections go down, so it looks like there are no new infections, then you lift the restrictions as China has done. And then 2 months later, you start seeing a new wave of infections as it builds up again and people start getting sick again. And so you have to clamp down on it again. And you go through these cycles each time with a lower but still massive amount of caseload, so to speak, in the society. And the trade-off, so basically what you can do is you can suppress, let people out for a week, and then put them back in self-quarantine until it goes back down, and kind of manage it that way. Or you can treat everybody massively with antibiotics that work, that don't let people get to the point where they have to be hospitalized. Those are kinds of the trade-offs that we're having to deal with.
Okay. So I'm getting lots of questions. This is from Jeff. For those of us on blood pressure medication, is there any truth that blood pressure medications interact with those medications? I assume he's talking about the two medications that we're talking about for treatment.
Yes. So probably not. I don't prescribe them myself. I don't, treat people clinically, so I can't say for sure, but I would suspect not in most cases.
Right. Okay. Question from Alan. Do we need to be concerned with taking out food from a restaurant?
Well, I'm even concerned about taking in mail from my mailbox. There's a practicality of things here, which is to say, you can always play it safe by washing your hands after you take the stuff out of the containers. Probably the food is okay. It's usually been cooked. And if you're concerned about the containers, empty them, throw them into your dishes or whatever, your own containers, and throw the restaurant materials away and wash your hands and then eat.
So I am going to try to bring in Joseph. Give a moment for Joseph to be with us. I'm waiting for Joseph to appear. While I'm waiting for Joseph to appear, I'm going to ask another question. Can someone get reinfected once they've had the virus?
I think that it's probably unlikely. I think what's happening is where people are tested positive after they've been tested negative is that they've been carrying the virus the whole time. And I think that there's in any test, there's always a small probability that the test is wrong. So you'll see if you test 10,000 people, there'll be some who test negative who are still positive. In fact, I was reading in Bloomberg Business Week the article on coronavirus where it was said that the tests in China were 95% accurate and we should extol that for our tests. And I'm thinking as an epidemiologist, that's almost a useless test because that means 5% of the people you test, you don't detect the virus when it's there. And if you're testing 100,000 people, you're going to miss huge numbers of people who are positive. We need tests that are 99% accurate or even higher before we actually place any reliability on these things. And so it's possible for people to test negative and then test positive only because the test is inaccurate.
Okay, I think I have Joseph. Are you with us now?
I am with you.
Joseph, we're ready for your question.
Harvey, for someone our age who's in good health, should we be taking any extra precautions?
Well, above stay at home, and stay at home, I think that's sufficient. I think that the question is how we manage life outside our homes. And that's a very difficult one to address. And I don't have good answers for that. And I'm very risk averse to start with. And so I'm trying not to deal with those kinds of questions about when to go to grocery stores, how to manage grocery stores, and things like that. I've tried to ask my colleagues about, are you more likely to get this infection from people breathing, coughing, sneezing on you, or from touching things that they've touched? And I've read reports, each one claiming that that way is the way that's most likely to convey the infection. And they would seem to be contradictory, that it can't be both ways are the most likely way. So I don't think it's well known how we get the infection, and therefore what methods we should use outside the house to minimize our exposures. I think common sense dictates what we do. And, if you drive up to the parking lot in the grocery store and it's filled, you're not going to go into the grocery store. Short of things like that, your common sense and mine are pretty much on the same level, trying to stay away from people as much as possible, and washing your hands after you've touched anything that other people might have touched. I think that's all we can really do.
So Harvey, I have a question from Danit. She says, in your local area, what are your recommendations for people over 70 in terms of going out to work and to stores?
Stay home. That the governor put us on stay at home, I think starting at 8 o'clock tonight. And I think that this should have been done a week ago. I think it should have been done across the United States a week ago or even earlier. In any case, the fact that it's being said really means that you only go out for really critical things. We live in a world today where we have so much electronic communication like we're doing now, like you could watch almost anything on TV or on video, that it makes life kind of so much easier to be entertained and to deal with working if you can work from home. That wasn't possible 10 or 15 years ago. So I think we basically have to be flexible to adapt what technologies we have to make life work for now until we get through this. And that really means staying at home as much as possible, trying to maximize what you could do yourself for yourself. And in my case, I have to figure out how to get my hair cut, but short of things like that, that you have to kind of try to use your common sense about minimizing the places and times that you would be exposed. And that's the best we can do.
Great, thank you. We have Harold on the line. Harold, are you with us? Harold, are you there? Okay, then I'm going to jump to a question I have from Cheryl. Is there any advantage to having a flu shot to guard against the virus?
Yes, but small. The advantage is that you're unlikely to come down the flu and be mistaken for having coronavirus. And so that's really important for public health management purposes, because we don't want lots of people that we think are positive who really have the flu. And that just makes it much more difficult to deal with the virus in the population.
So I have a question from Sharon. Can you point to a solution in the shortage of medical equipment in healthcare? How bad is it for healthcare professionals to use one mask for an entire day?
Not great. And this is something that they're protecting themselves, but they're not protecting the successive patients who come through their care. And their first priority is to protect themselves, because if they don't, then we won't have any healthcare workers. So they have to do that, but they have to be able to protect the people they work with that they serve, and I think that they care for. And I think that you can only do what you can do, but you have to fix that as rapidly as possible.
Okay, so I have Ria. Ria, are you on the line?
Yes. Hi, David. How are you? Hi, Dr. Risch.
Hi, Ria.
Oh, so my question is, what can we do to build our immune systems?
There really isn't much that one can do other than staying rested, getting reasonable amounts of exercise. I think that's about all. There's no proven remedies of food or other things that will help other than rest, exercise, nourishment.
Dale, are you on the line?
Yes, I am. Everything you read on the net, a lot of it is not true. I read something that one of the symptoms of the virus is your sense of taste and smell deteriorates. Do you know anything about that?
So I've read probably about as much as you have, and that seems to be true for somewhere between a third and a half of people who become symptomatic, that they lose their sense of smell. And of course, if you lose your sense of smell, you lose most of your sense of taste, because most of taste is actually smell. And that happens for a couple of days and then goes away. That seems to be true, that people have been noticing. I can't say that that's medically proven, but it's commonly reported.
So I have a question, one that was emailed to me, and then a similar one that just came up on the chat. And I think we'll put it into a more generic category too. The one that was emailed to me was, there's been mention of potential benefit in gargling and drinking hot beverages on a regular basis to wash away the virus. Someone just said, I've read that drinking hot liquids and using mouthwashes can help fight off the virus. Is there anything that folks can be doing at home like that to fight off, to wash away the virus in any way, or is this just folklore that's making its way around the internet?
I think it's wishful thinking in desperate times that we have control over how we can deal with this. I think that you'd have to be washing continuously. Otherwise, it's going to regrow back from the nasopharynx, from the nose and behind the nose. That's a lot harder to wash than the mouth and throat. And trying to get it to wash the larynx, getting it down to the lungs, there's almost no way to wash that. So I think that it's pretty difficult, and I don't think that that's going to be very helpful, likely.
So Harold is asking about best practices when you go to the supermarket. Have you gone to the supermarket recently, Harvey?
Nope.
Nope. If you were, or if someone was, what would you recommend to them as best practices? That's a place where people are touching everything that you end up touching. So
facetiously speaking, I'd say wear a mask, because even though wearing a mask doesn't do anything for you, it frightens everybody else away. So that makes everybody stay more than 6 feet away from you because they think that you're sick. That's why, in fact, there are some countries that make everybody wear a mask if they go out, so that there's no stigmatization about people who are or are not sick when they're wearing them. Honestly, I don't know that very much matters other than staying away from people. I don't know if wearing gloves helps or not. I think that all of these things are low cost and simple. And as long as you have the resources and the availability of the items to use, wearing gloves there's nothing the matter with that. I think that the main things are, you're going to end up touching things anyway, even wearing gloves. You just don't touch your face. And you have to, you take the stuff in, unpack your food. You're going to have to unpack your food from whatever you packed it in. So you're going to have to wear gloves for that. Or you end up just washing your hands carefully after you're done with handling everything that you brought from the grocery store. My colleagues have said, at least as of a few days ago, that paper goods and products are not likely to transmit the infection, and therefore picking up boxes that come from Amazon or taking in the mail or things like that are not likely to convey the infection. Again, this is incomplete knowledge. We don't really know, but they're saying that they connect people to people for how the infection is spread rather than people to things to people. So we're doing best we can by washing our hands, and that's crucial, but that's only one part of it.
So the question I'm seeing from Rick on, can the virus be passed on delivered mail or newspapers, you're not as worried about?
No, I'm not. I still have anxiety, but I'm not so really worried about it.
Right. So I see a question about the use of alcohol externally or internally. I think primarily for hand washing, if Purell is not available, this is a good second choice.
Well, it's actually a different alcohol. Rubbing alcohol is the kind you put on the outside, and ethanol, drinking alcohol, is the kind you put on the inside. Yes, the Purell will work as a substitute for hand washing. Hand washing is better, but if you don't have it, Purell is a substitute for it. And alcohol on the inside is a personal choice.
We have time for one or two more questions if anyone wants to raise hand or submit a final question. I'm going to look at how long do you expect us to be on lockdown is a question that I got on the email.
I expect that the longer we're on lockdown, the more people are going to push back, that it will become more and more difficult after a couple of weeks. And I think that we're going to have to see a real downturn in the numbers of cases before we decide that the lockdown has been successful in doing something. So it's hard to know for sure exactly. And this is a social value that basically equates with the economy working versus more people dying out there, especially older and otherwise sick individuals, people with other conditions. So that's a social value trade-off, a moral trade-off that I obviously can't make, and I don't know how a society could make it. For example, the Netherlands has already made that decision by not quarantining anybody and letting the whole society just intermix, and whoever gets it, gets it. And they did that decision without even having any medications to use. So honestly, I don't know. Their social values are different than ours.
So Danita, are you on?
Yes.
Your question?
Hi, Harvey. My question is that I have a limited amount of time off and I work at a hospital in the New York metro area. And I was thinking maybe it's better to be taking the time off now while it's still on the rise, but I am limited. And some of my colleagues are saying, well, it could go on till August. Don't use it all up now. What would your recommendation be?
Oh, I would definitely use it up now. And the reason is that the longer you wait to return, the better the protective equipment availability and treatment medications will be by the time you return.
Okay, thank you.
All right, so I'm gonna ask you just a couple final questions. One comes from Judith, which I think is a good closing question, which is, how can we manage the fear that people have?
Well, a lot of this fear is the uncertainty, and am I likely to get this? Is it likely to be harmful for me, fatal for me? Those kinds of anxieties. And I think we have to be reassured to some degree that it's still very infrequent that even the people who are mixing in the general public who've gotten it, and even among people who've gotten it, the number who've gotten sick is a relatively small proportion. And among the people who get sick, the number who have to be hospitalized is half of that. And then among the ones who are hospitalized, only half of those become really seriously ill, and so on. These are diminishing proportions. And especially once we have medications, when we can use them early on in the symptomatic disease process that keep people out of the hospital, I think we'll all feel much more relieved that we have a backup method for dealing with the disease that we may in certain ways think of as inevitable, but that we can cope with.
So I have a few more questions that are coming on in the chat, and then I'll ask a closing one. Rick asks, I have gloves and masks for my office. Where should I donate them where there's the greatest need in our area?
There's a website, which I'm forgetting now, that I don't know how it triages them, but at least it's a starting place. But I think that maybe the Department of Public Health has an idea of where to do that. I can't give you an exact link, but I'm sure if you look on the Connecticut Department of Public Health, they may have a link there.
Great. Rebecca asks, are pregnant women getting infected at disproportionate rates?
No more so than all the rest of us. The infection rate is how much you're exposed and to whom you get exposed from.
And Sharon asks, does the virus cause permanent lung damage?
So as far as I know, no. The Lung Society says that it doesn't. The indications are that people who have severe pneumonias from flu or from bacterial pneumonias recover and don't have permanent lung damage, that they repair their lungs. So my sense is probably not.
So Harvey, I just want to ask as a general closing question, whenever this is behind us, whether it's 6 months or 12 months or 18 months or 24 months, how do you think life looks different? How would you like it to look different on the other side of it in terms of our behaviors?
So I think of this the way my parents and grandparents felt in 1930, that they had just suffered a massive depression that was caused by an economic policy that was disastrous, that didn't really make people out of work because there wasn't work for them, but because the whole business model was faulty. And now we have people who are being dislocated because of a public health model that is causing the same kinds of ultimate dislocations and economic dislocations in society. And I think we're going to come out of that with people feeling like, I survived, I managed, I got through it. It was hard. I took a loss financially, maybe, but you know, maybe it changed my lifestyle and lowered my standard of living a little bit. It's possible. It will take a while to recover. It might take a few years to get back on track. I think we have a very different economic system now that we might be able to get back on track in a year or two rather than 10 years after the Great Depression. So I'm a little more optimistic. I think people will be back to their usual things. We'll have inter-party bickering in the political sphere, just like we had, you know, until a week ago, and probably still have to some degree now. I think that, you know, being human will return and we'll get through this like most things. I don't think it will change the character of our society. I think we may, however, be a lot more motivated to maintain our critical infrastructure within the United States rather than farming it out to other countries. I think that Americans will be much more likely to pay slightly higher prices for drugs, you know, to make sure that they're available here when they need them and things like that.
And do you think this leads to any changes globally in terms of health policy, how countries communicate with each other?
Well, I think it's been helped now. There's a huge amount of global communications now. I think it didn't start that way, obviously, but I think that's improved. I don't know exactly how that will change in a practical terms other than the fact that we do have better communication about evolving threats, but how we manage them is going to look like this. If 3 years from now another virus escapes from China or somewhere else that is very infective and goes around the world, we'll be back to doing exactly what we're doing now, and it won't seem any different. So it's really hard to know whether. I think part of the problem that I see is that our business schools and business infrastructure has created a just-in-time society for everything. And we don't stockpile very much. There are some things we stockpile, like we stockpile oil, for energy reserves for the United States, but other things that we don't stockpile, and then suddenly we, like ventilators, and suddenly we see we need them and we don't have them. Or medications that we may need that are being manufactured outside the country and so on. We can't get them fast enough and so on. I think that we have to reassess our self-reliance mentality and figure out how we can maintain some compromise between not having to hoard everything in the world in order to protect ourselves, but at the same time being prepared enough that when things happen, we have recourse.
Yeah. And Harvey, for all the folks who are watching this now or will watch it later, what's the 2 or 3 things that you want to urge them to do?
I'd say stay home, stay home, stay home. Figure out ways to get all of your activities done. If it's with kids, having them occupied, educated, entertained, yourselves as well, somehow managed as best you can that way until we get through this. I think that the only way we'll get through it is if people socially isolates to a very strong degree, and that's what we have to do.
Harvey, Dr. Risch, thank you so much for your time, for your insight, for your expertise, for your generosity in answering so many questions of so many kinds on this call. I know that most of us don't have the opportunity to have to speak to someone with and ask questions to someone with your level of expertise, and it's great to be able to go directly to someone like you with our questions.
My pleasure. I wish they were more known, but we do what we can. Thank you.
And thank you so much. Have a good night. And for everyone who's listening, thank you for participating. Thank you for your involvement and all of your questions. And we're going to continue to give you more opportunities to learn, including this Wednesday at 4 p.m., which will be our next Federation-led webinar with Andrew Banoff of Jewish Senior Services and Matt Greenberg of Shoki Jewish Family Services to talk about how our significant local Jewish social service organizations are changing and adjusting to this current situation, how you can help them and how they can help you. So please tune in this Wednesday at 4 p.m. Harvey, Dr. Risch, thank you so much for your time. Good night, everybody.
My pleasure. Good night.